Agni.
Hi, Agni.
How are you, sir?
Fine, thank you. How are you doing?
Good, sir. Good. Good.
Tu kaisa hai? Good.
I'm
Blasting
fine, sir.
off.
Fine.
Yeah,
No,
Mumbai
not
is rocking.
Only in terms of corona.
Yeah, it's rocking Corona, yeah.
I think, sir, Bengal is also undergoing a lockdown now, na?
Yeah.
Yeah, but Bengal is picking up a little bit later on the heels. You know, Mumbai took up first, followed by Delhi, then it was Chennai, and now Calcutta is really picking up.
Okay. Sir, we are live. Good
Acha,
evening.
Neeraj, before we start, what's the time? It's one hour.
Yeah, total 1 hour.
So we'll talk about 20-25 minutes, Raghu, and then about the primary benign ones, and then take some questions, and then again start with the malignant ones.
Okay, but how much is
otherwise it becomes too boring.
How much is your total time, basically? If you take the talk as a time phase, how much is it?
I think it will be a half hour, 35 minutes, but it's very boring to go on talking for half hour, 35 minutes. We'll take a break after the malignant, after the benigns are over.
Okay.
And then take some.
So that will be about what, 10, 15 minutes?
20 minutes, 20
okay,
minutes,
perfect.
Followed by 15 minutes, then another 10-15 minutes, another 10-15 minutes. ऐसा करके करो.
Okay. So what I thought was I'll introduce you. And then
Raghu, we are already live.
Yeah.
Like, basically,
Sure.
let's. Yeah.
Okay. Hi. So everybody, hi. Welcome once again for a session of the Navi Mumbai Orthopaedic Association webinar series under the auspices of the OrthoTV. After having covered a lot of subspecialties in the field of orthopedics, including spine, as we had one with Dr. Sachin Ahuja, this time we are returning back to spine as a specialty, and we're going to talk about primary tumors of spine. Now, for an orthopedic surgeon, he would say that it's a rare thing in clinical in our clinical practice, which leaves us with enough and more questions that need to be answered with respect to the diagnosis, the differential diagnosis, and the management protocols. Who better to answer all these questions than Dr. Saumyajit Basu from Kolkata? Dada, as we call him in our circle, needs no introduction, but I think I'll just, as a part of protocol, put it across to all of you all where he's from. He's graduated in 1992 from Kolkata Medical College, postgraduate MS Orthopedics from the R.G. Kar Medical College, then pursued the FRCSN and did a spine fellowship at the Queen's Medical College, Nottingham, UK. He's presently the head of the department of the Kothadia Medical Center in Kolkata and visiting to the Park Clinic in Kolkata. He is a chair of the worldwide course coordinator for the SRS. He's an ex-secretary of the Association of Spine Surgeons of India. He's a vice president of the Spine Society of Bengal. And he's in enough and more editorial board member of many journals of repute. He's had enough and more publications and podium presentations to his credit. So without much further ado, I invite Dr. Saumyajit Basu to start off this session. Saumyajit.
Thanks, Raghu. It's actually an absolute ecstasy to speak in front of you and Agnivesh, and I am honored and really flabbergasted, if I might say, to speak in front of the Navi Mumbai Orthopaedic Association. Here are my disclosures. So today's topic is primary tumors of the spine. What we decided was we were going to cover the benign tumors first and then the malignant tumors. So vertebral tumors are either benign or malignant. The malignant ones are primary, secondary. This is common knowledge. And spinal cord tumors are differentiated from vertebral tumors in being extra or intramedullary. Now we are basically going to restrict our talk to this particular segment of spinal tumors. Now, as you all know, that primary spinal bone tumors account for less than 10% of all spine tumors. In all bone and soft tissue sarcomas, only 10% are related to the spine, and 97% are metastatic. So we are dealing with not only a rare entity in spinal tumors, but also a rarer entity in orthopedics. I'm not sure how much of you would be really interested in this, but bear with me for some time so that we can go ahead with some fruitful discussion that might awaken you out from your drowsiness. So as we all know, pain is the most common clinical presentation. Night pain or pain at rest is classical. And benign tumors usually have a long-standing indolent design of pain, but malignant tumors have rapidly progressive severe pain. Neurological symptoms can range from root symptoms to complete paralysis due to a mass effect or instability. And constitutional symptoms usually seen in malignant tumors. They might present with spinal deformity and with bladder and bowel dysfunction. We all know that in many of these CRP can be raised, especially in malignant tumors, and the relevant investigations like protein electrophoresis, PSA, thyroid function test, CA125 and CEA are very important. As is chest X-ray and CT, this is a typical secondary deposit. A primary lung cancer came to the secondary deposit. USG whole abdomen and a CT of abdomen pelvis with a contrast is essential. Now, we all know about the winking owl sign, the vertebral body destruction. In MRI, it is nice to have a contrast image because the neural tissue compression and the delineation of the soft tissue extent of the tumor is very well done with the MRI with contrast. And a CT scan is imperative to show you the amount of bone destruction, the geometry of the tumor, the exact amount of osteolysis, and the exact amount of bone involvement which are there, including the expansile lesions. PET scan is now very commonly done, and I would assume that most of the bone tumors undergo a PET scan nowadays. Biopsy remains the gold standard, and here is a typical example of a situation in which there might be a discussion regarding whether biopsy first or surgery first. What I say to all my fellows is that if it is a patient presenting to you with a rapidly progressive, fast, and massive neurological deficit, you might go for surgery, but otherwise it's always a biopsy first. Now, this is a revision of the Enneking staging of benign musculoskeletal tumors. As we all know, Enneking 1, 2, and 3 is dependent on whether it is inactive, active, or locally aggressive. And to revise the oncological margins, there might be surgical resection, might be intralesional, marginal, wide, that means with a normal tissue cuff all around the tumor, and radical, that is taking out the entire compartment. Now, in benign tumors, curettage, electrocautery, cement augmentation, adjuvants like phenol, cryotherapy is always there, but the balance is between the extent of tumor resection and preservation of spinal stability. So if the spinal stability is compromised, as is often the case in many of these benign tumors, fixation and fusion is mandatory. And the staging systems of malignant tumors just needs to be revised in one slide, in which we know that depending upon the histopathology, it is low grade or high grade, and stage 1A and B are just like stage 2A and B, in which they are intra or extra compartmental, and distant mets is always stage 3. Now, Stefano Boriani, Milan, Italy, has worked out beautiful localization of the disease, especially important for benign tumor section of the spine, in which he has focused on 6 segments on each side of the cross section of the spine, and has got 5 layers from soft tissue to the dura, and has a longitudinal extension depending upon the levels. So this is the axial section in which each side of the spine is divided into 6 parts, from the posterior to the anterior, and the posterior would start from the spine and the adjacent part of the lamina, and part 6 would be number 6 would be the anterior 1/3 of the bone. And before going on to the common primary bone tumors, I might remind you that a proper clinical examination, a proper radiological analysis is extremely important to understand the approach of your treatment. Now, to classify common primary bone tumors, we have either benign or malignant forms. The benign forms are very easy to remember if you remember like this, that it is either of vascular origin, that is a hemangioma or an aneurysmal bone cyst, or it is of chondral origin, that means cartilage formation. There is the tumor cells which are predominantly cartilage, which might be chondroma, osteochondroma, or chondroblastoma rarely. And this lineage goes on into chondrosarcoma if there is excessive mitosis. And the osteoid lineage, that means in which the tumor tissue laid down bone, mature bone matrix, is either the osteoma, osteoid osteoma, or the osteoblastoma. and they move on into osteosarcoma in the malignant group. And from the cartilage-forming tumor cells to the osteoid-forming tumor cells, we have the spindle-shaped tumor cells, which is the GCT. Remember that the giant cells are not the tumor cells, it's the spindle-shaped stromal cells, which are the tumor cells. And there is also the lineage of eosinophilic granuloma or the Langerhans cells, histiocytosis, the LCH, which is the last part of the benign tumors. So it is a vascular cartilage bone, spindle shape, or the histiocytes, which might be the benign forms. In the malignant forms, we know that the primitive neuroectodermal tumors, including the Ewing sarcoma, is a very malignant tumor, and they also have a stromal spindle-shaped cells with high mitosis. The chondrosarcoma, as we know, that it is from the lineage of chondromas, which turn malignant, and the osteomas, which turn the osteoid tissue, which turns malignant, is the osteosarcoma. The myeloma tissues, that means the bone marrow cells, the plasma cells, as well as the lymphoid cells, they might be the source of the primary malignant tumors of bone, which is the plasmacytoma or the lymphoma with the Hodgkin's and non-Hodgkin's. And of course, chondroma is supposedly from the notochordal cells, which also is a malignant tumor, which has a distinctive origin, distinctive course, distinctive affection of the spine, and has got a distinctive treatment in the form of surgery and surgery and surgery, nothing else. Now, osteoma is a very slow growing lesion, and we all know that osteoma is more often in the calcareal bones, and osteoid osteoma and osteoblastoma can occur in the spine. They're histologically very similar, and osteoid osteoma is usually accompanied by nocturnal pain relieved by salicylates, whereas osteoblastoma predominantly arises in the axial skeleton, spinal lesions constituting 1/3 of reported cases. They are histologically quite similar, but they're clinically quite different. Regarding the chondral lesions, as we all know that benign lesions are osteochondromas or enchondromas. Typically, intermediate are the chondromyxoid fibromas and the chondroblastomas, and atypical chondrosarcoma grade 1 and the malignant are the grades 2 and 3. Now, in the upcoming WHO classification, the later one, chondroblastoma and chondromyxoid fibromas have been totally taken out, and they're either benign or malignant, and chondromyxoid fibroma has been put in the benign word. So we have osteochondromas or the enchondromas as along with the chondroblastoma as well as the chondromyxoid fibroma, which are all benign, and the rest are all malignant. Posterior elements are primarily involved in the osteoblastoma, that means the osteoid cell lineage, the tumors, and the ABC, whereas the tumors primarily involved in the anterior elements are the GCT, hemangioma, and the eosinophilic granuloma. If you look at the age distribution, there are two typical age distribution level. One is the 20 to 40, that means the young adult or the in the 20s and 30s, that's the GCT and the hemangiomas, whereas the eosinophilic granulomas and ABCs, the aneurysmal bone cysts, are usually a little earlier, usually between 5 to 15 or 18 years. And this is very important to differentiate between these two tumors. You will notice that primary benign tumors are very rare over the age of 40. Mostly they are malignant, if at all they are primary. Mostly they are secondary tumors, and if at all they are primary, they might be malignant in the form of chondrosarcoma, which is commonest. So let us look at a few clinical examples, like say hemangioma, and in these are they're very benign tumors, and they are mostly incidental findings. And 10 to 12% of autopsy specimens as hemangiomas, about 1% are symptomatic. I'll pause here to tell you that symptomatic is only when they have microfractures or trabecular fractures leading to collapse, or when they have neurological deficits. And as you will remember, that these neurological deficits are a very rare symptom. They usually come to with pain, if at all they present with any symptoms. The established treatment protocols are still not there. There are very many sort of protocols which have been tried by various institutes, and various treatments like vertebroplasty, kyphoplasty, radiotherapy has been used. Surgery is only for neurological deficits or severe pain. I'll show you an example of a 63-year-old male who came to us with spastic lower limbs and a sensory level of D10. And as you can see, this is the hemangioma, which has a typical posterior extension. You will notice that this is actually a hugely dilated vascular network which compresses the spinal cord, and this leads to progressive paraparesis. And we have a very novel technique of addressing this. We firstly do exposure, one up, one down, putting pedicle screws up and down, and then do posterior element resection to make sure the decompression is complete from the posterior elements. And then we do a vertebroplasty, and that is how the vertebroplasty looks like. And then we fix up the rods, and we can go anterior. On one side, we fix up the rod, and we go on anterior to the lesion and take out the whatever is compressing the anterior part of the cord. Believe me, after the vertebroplasty, as all the vascular channels are blocked, the capillary network, which actually compresses it, the anterior part of the spinal cord gets very shrunk, and it's quite an easy job to decompress the anterior part of the spine. And this is the post-operative 7 years X-ray, and that is in 7 years. He came as a non-walker, and as you can see him 7 years down the line, he's completely symptom-free. A typical example of another 46-year-old male who came to us with grade 2 to 3 power, and this is again the hemangioma, and again we did a similar surgery, and we've done about 8 or 10 out of them, and all of them were very gratifying. So let's look at giant cell tumors. Osteoblastoma is typically diagnosed between 20 to 50 years, and they primarily affect the epiphysis of long bones. Affection of the extracellular is rare, and spinal discity accounts for about 15% of all discities typically occurring in the anterior elements. Main presenting symptom is the pain. They are of long duration until unless they are actually very progressively expansile, or they are affecting the neurological system. They are usually not present to you at all. Mainstay of discity has remained for decades together interlesional curettage accompanied by packing of cement or bone grafts. But for axial discity, the recommendations are less clear, and from splenectomy to Denosumab, the range is huge. Currently, Denosumab has shown extremely promising results recently, and there are very many institutes across the world, including Stefano Borriani's center in Milan, who've come out with guidelines of Denosumab therapy and our series has been extremely gratifying. For example, this is a C2 osteochondroma, osteoblastoma, as you can see. It's a complete expansion lesion, and we just did a transoral biopsy, transoral wide bone needle biopsy, and after the diagnosis was that of GCT, put her on a halo and a Denosumab. And after 2 years of Denosumab therapy, as you can see, there is complete ossification. It is stable. This joint has reformed, and it is absolutely painless. She's now about 3 years down the line on regular follow-up, and she's doing extremely well without surgery. Again, this is a patient who had a very severe compressive myelopathy, a 37-year-old. As you can see, the contrast shows the area of the bone which is involved and the amount of resection which was done after a preoperative Denosumab therapy. And this is him. This is him after surgery, and there is a very good follow-up of about 2 years now we have on him, and he's doing extremely well. Resection is possible. Complete resection is possible for a grade 3 GCT of sacrum, in which we did this resection, and he unfortunately recurred because this was a piecemeal resection, and we had to give him radiotherapy after he was there 3 years with bladder affection, but then was lost to follow-up. We've had only one case of LCH in our series. It is gone in for, it has been submitted for publication. Usually in children, they have vertebral plana, and in adults, it's extremely rare. Intralesional curettage is occasionally required, but most often they are treated in adults by radiotherapy. Look at aneurysmal bone cyst. This is a benign expansile lytic lesion of bone, which is thick-walled, containing blood-filled cystic cavities, commonly seen in the adolescent population, never present over 40 years of age, and usually they present anytime between 10 to 25. And the adolescent population, other than the fact that they're affected in the adolescent population, they are also affecting the posterior elements of the spine, and spinal lesions account for about 14%. Pain is the presenting symptom, and multiple fluid fill levels is characteristic in the MRI and CT scan. And these are patients who the classical treatment is curettage and electrothermal burning. And we have actually done a lot of vertebroplasty on these patients, and at least 3 of them are still on follow-up, and all of them are doing extremely well. So this is a 22-year-old male, and as you can see, there is the cement. It flows extremely well in the cavity. If you are very sort of careful at injecting the cement at the correct down phase, they give a very good relief, and there is no recurrence at 6 years follow-up. We've had one patient of chondroma who was a 24-year-old male, and this is the lesion. As you can see from the CT scan, that there is an extensive lytic expansile lesion, and the FNAC was that of a chondroma. An osteochondroma is something which is which needs a very, very high index of suspicion, and they can be in any part of the spine, but the dorsal and the cervical are typical. And these tumors grow by enchondral ossification. Osseous parts of the tumor is covered by a cartilaginous cap, which is unique to this tumor. And multiple hereditary exostosis, MHE, is autosomal dominant, and it is this group which is a little bit prone to turning malignant, but the other ones are usually benign. And osteochondroma usually do not present until unless it is impinging on some particular important structures, and asymptomatic lesions are just observed. If they are symptomatic, it requires excision. A typical example of a symptomatic osteochondroma was a 10-year-old female presented to us with myelopathy with an osteochondroma at the posterior element of C2, which is compressing the cord, as you can see. And an en bloc resection was done, and this is the postoperative X-ray and the CT scan, which shows a complete removal of the tumor mass along with an excellent decompression of the cord. And 4 years postoperatively, she does not have any major instability, and she is doing well from a wide excision of the tumor mass alone. Osteoblastoma is again a locally aggressive lesion commonly seen in the posterior elements of the spine. 40% occur in the spine. So this is one particular benign tumor of bone, which is commoner in the spine in other parts of the skeleton and seen in the 2nd and 3rd decade of life. Pain is usually the presenting system, and histopathologically they are very similar to the osteochondromas and can be confused occasionally with osteoid osteomas. This is an example from the internet of osteoblastoma. All the other pictures are from my series, and this is an example of an osteoblastoma. Osteoid osteoma, as you all know, have a night pain which relieves on anti-inflammatory drugs, and this is the diagnostic test. Adolescents again, and many of them will present to you with painful deformity. So if a young adolescent presents to you with a painful deformity, usually adolescents in the thoracic spine, their deformity is not painful. The typical idiopathic scoliosis are never painful. And if they have a painful deformity, always suspect that they might have osteoid osteoma. Observation can be tried, but very few are self-limiting. Sometimes the nidus may not resolve at all. Excision of the nidus with or without the sclerotic bone is the treatment of choice. However, percutaneous RFA, the radiofrequency ablation, has been shown to be an excellent pain relieving mechanism in many centers, and many of them recommend that for accessible areas, that means when the lesion is not too close to the neural elements, this can be the treatment of choice. We operated on a patient of a 12-year-old female who presented to us with a deformity of the back. And as you can see, that the lesion was basically this one, and this was involving the pedicle and the soft tissue edema, especially visualized on the stir sequence, is very typical. You can see this is the inflammation of the muscles, inflammation of the soft tissues around the lesion, which gives the typical characteristic feature of MRI of these lesions, and they are occasionally very poor in contrast uptake, and the thickening of the pedicles and the sclerosis is very typical of the osteoid osteoma. And on the CT scan, you can see that there is broadening. At one point in time, we thought whether it's a Brodie's abscess or not. and this is broadening and hypersclerosis with the PET scan shows increased FDG uptake. Initially underwent biopsy and which was inconclusive, and she underwent radiofrequency ablation first, to which she didn't respond, and finally we had to excise the lesion with complete relief of pain. I'll stop here and take questions so that it doesn't get too boring.
Yeah.
Before that, Raghu, if you have any questions, I'd be happy to answer.
Sure. So if I can start off questions and Agni can join in. One thing I wanted to ask you, Dr. Basu, is that of all the benign tumors that you've seen in primary spinal benign tumors, what's the commonest that you've seen in an Indian perspective? Because the West and all literature that we have generally comes from the West. What's your experience in the commonest ones that you see?
Just before I finish off, this is the post-operative picture of this patient of the osteochondroma. I mean, osteoid. This is the post-op. I mean, the 1 year follow-up X-ray that you can show the deformity is well corrected, and we took up this entire pedicle.
Yeah, sure.
Pedicle, and this is her clinical.
Sure.
So I'll stop slide share now and take questions. Yes.
Yeah. So the first one.
So the commonest tumor is always hemangioma, which is across the world. I mean, the commonest tumor is hemangioma, and they are very, very, very rarely symptomatic.
In the group that you are symptomatic, where you've had to operate in the hemangioma, since I saw your slides there, do you have the protocol of doing a pre-operative embolization of the lesion before you do and end up doing a surgical intervention, or you don't practice it as a concept? Because one of the issues is the amount of blood loss that you can have in a hemangioma. So
that is what, Raghu, I've been following this patient up quite closely. I did do embolization for the first couple of hemangiomas. Okay. But then once I've started to pick up these cementing techniques, I find it absolutely fantastic, because it blocks all the blood vessels and you can see the bleeding coming down. Once you just put in cement, be slow and steady, and try to fill up at least 80% of the vertebral body with cement, you do not have bleeding after that. And that is why in those patients who present to us with myelopathy, my strategy is to do a open laminectomy first, because the posterior elements are hardly ever affected by
hemangiomas.
Affected by hemangiomas. So excision of the posterior elements and doing a good decompression of the cord or the cordaipin or whatever you say, depending on the level, is very safe. You've put in screws up and down, you've done a laminectomy, and then you fill it up with cement. And as the already laminectomy is open, cement leakage can easily be seen, if at all. I've never had one. So it is a myth that the posterior elements, I mean, the posterior leakage of cement can be seen and very. They do not, because you are doing it live under the vertebroplasty, and reasonably experienced spine surgeons do a lot of vertebroplasties every year. So we can put in cement. Once it is flooded with cement, there is absolutely minimal bleeding.
Interesting,
and it is
interesting because we generally
as the cement also gives us stability, that obviates the necessity of anterior column reconstruction also.
Correct. So, Dr. Dhar's joined us basically. Yeah, he's got a question. He's basically.
Yeah, thank you, Dr. Basu, for an extensive presentation. I just wanted to ask, in hemangiomas, do you use any criteria when you need to operate? Is there any? Do they always need to be operated?
So I never operate on them. In fact, as I showed you the slide,
hemangioma which is clinically presenting itself. So, do you use any
the hemangioma?
Yeah,
hemangioma which is symptomatic either with pain due to a pathological fracture or due to a neurological deficit, usually with myelopathy, the major neurological deficit. In these only I operate, and for the last.
In such
I'll just finish,
do you use any criteria, in the sense mechanical criteria, or whether the neurodeficit is progressing or it's a stable, maybe you need not operate? Do you have any protocol for that?
No, I don't have any protocol. There is no established guidelines of indication of surgery staging wise. I am not aware of any, but I would offer surgery to any hemangiomas which have become myelopathic beyond grade 3, possibly grade 3 motor power, just barely a walker. I would definitely offer surgery. And the second group which I would offer surgery is those who are symptomatic due to the hemangioma. Now, as we know that localization of the pain is an extremely important challenge in most of these back pain patients. If you find that this is the cause of pain, just do a vertebroplasty. They will have excellent relief. Do a percutaneous vertebroplasty only. I found it very. In fact, initially in the first couple of these instances of vertebroplasty, I would do it with neural monitoring because I was so afraid. But of late, I do not do neural monitoring for all the myelopaths, but for back pain patients with vertebroplasty alone, I would not do monitoring.
Yeah, one more question, Dr. Basu. Your experience. Hello, are you with us? Yeah. So your experience with Denosumab, how long is your experience now with Denosumab in terms of follow-up?
So
How long is it? Hello.
I think he is disconnected. I think
Yeah,
sir is
yeah,
disconnected.
looks like he's got disconnected by some reason.
What happened?
He's got disconnected. Again.
Yeah, hello.
Yeah, are you with us?
Yeah. I'm with you. So my longest follow-up is now 4 years of Denosumab, and I'm
Okay.
still learning on this. And I feel that it is a real neoadjuvant therapy which is going to change the indications of surgery completely over the next 5 years. Already there are centers in Milan and in Belarus, in Texas, who are shifting over to Denosumab completely. And there are two patients of mine. One is a sacral and the other is a C2. In both these GCTs, the sacral GCT is a 18-year-old female. She initially came with a very mild bladder problem and a gastrocsoleus weakness, and it is a huge sacral hemangioma. And she's now 3 years down the line. You wouldn't believe the amount of calcification and the pain relief, as well as the return of the gastrocsoleus power also, which has come back. So I'm very loath to offer surgery. So I'm just going on following her up. Now we are cutting down to once a year because it's the 3rd year now, and I'm really awestruck by the results.
Agni, you want to ask something?
Yes, since the discussion is going about hemangiomas, what was going previously, I have one question for Basu sir. Is that a group of surgeons or some surgeons believe that if you're looking for choosing a hemangioma which is symptomatic, you may want to choose the ones which are positive or which are bright on stir imaging rather than the ones which are bright on T1 or T2 because of fatty. So what is your experience regarding the thought, sir? Means would you choose the same patients, or you have done both, the ones which were stir negative and stir positive? And is there any difference in outcome?
Stir positive hemangiomas, you mean to say?
Yes, sir.
Yeah, star positive hemangioma, star negative hemangiomas are not very symptomatic usually, because they would suggest that there was a pathological fracture which is healed, and star positive are if the patient is presenting with back pain alone and it is a star positive hemangioma with the CT scan showing that there is a collapse, or occasionally a trabecular fracture can be extremely well picked up on the CT scan. In those patients, I would definitely correlate this fracture. But if a patient comes to with back pain, and so for example, an L3 hemangioma with a little bit of collapse, which is not bright on the star, I would be very loath to offer him any sort of vertebroplasty, because possibly the pain is not coming from that.
All right, sir. All right. That makes
Saumyajit, one more question, if I can. My question is, how many times have you had a primary diagnosis in your mind with all the imaging being primary bone tumor, and it's come out either an infection or COX or TB? For the benefit of all of us, how many times have you had that experience that your biopsies come out after all your experience?
I would say if it is about if it's a diagnostic dilemma. If I were to toss a coin 10 times, I would say I would be wrong in 2 times, and out of those 2 times, one, it would be my diagnosis is a neoplasm, it has come out to be TB, and in the other, my diagnosis is TB, it has come out to be neoplasm.
Okay. So about 20% is wherein probably you've had a surprise, I guess so, right? With after your so many years of
Yes.
experience, you still
And
can.
it goes in either way.
It goes in either
Yes,
way.
yes.
Because it's important
And
because
that's
all of
also
us.
to
Go ahead. Sorry.
no, and that actually emphasizes the issue of a biopsy and a biopsy and a biopsy for treating all osteolytic lesions.
Sure. Makes sense. Dr. Dhar, you want to ask something?
Yeah, sort of an extension. Now, with your present knowledge of Denosumab in giant cell tumors, would your strategy, in accessible areas, I'm not talking of your C2 and sacrum, I'm talking of accessible areas, would your strategy be still like curettage, intralesional curettage, cementing, and or should you give Denosumab in all the cases first? Because even cement, panacea that you can, every giant cell tumor will finally heal with a cementing.
Maybe Sanjay, I'm sold out, but I would straight away offer if it's a accessible area also, I would just not do any sort of surgery on these patients until unless they have some pathological fracture or neurological deficits. If it's a patient who presents.
Hello.
Kolkata network is poor.
Kolkata network is tough.
Using them regularly would really be sort of.
So Saumyajit, we lost you somewhere in between. I know it's trouble, but can you just repeat what you said because we lost our.
Yeah, so for all patients whom I have made a biopsy diagnosis of a giant cell tumor, I would not hesitate to straight away put them on Denosumab.
Okay.
Straight away. Okay. And I would not go in for any surgery until unless I am sort of pushed into doing that.
So somewhere I think that's become your principle. That's your first line of defense, as we understand, basically.
Yes.
So are you
studying? Mine, I think it's across the world.
Means are you studying your C2 patient or whatever you sacrum? We have not seen that. Means what are the changes happening now over prolonged use of Denosumab? Normally the conventional teaching is that you need to stop it at some stage or other. So what is your experience now with those two cases you have?
I think I can just, if you give me a minute's time, I think I'll share with you this presentation. Just share the screen with you once.
Yeah.
This is a 47-year-old female. This is one of my very early cases, which was a T1, T2 GCT, in which we did a front, back, and all that. But look at what happens. I'll show you some examples. Hello?
Yeah, we can see it now. We couldn't see it. We can see it now. Please go ahead.
Yeah, so this is the patient whom, this is the detailed slide of the patient of C2. This is what she came to us with flexion extension, severe pain. And this, you can see this is how she looked like. And this is her post-Denosumab. This is about a year down the line. So GCT in C2. So this is what was initially, and that's how she came to us. And the other is a sacral GCT. Look at this GCT, is a 17-year-old female. She's now about 3 years down the line. Everything is gone. And look at what happens with Denosumab. Everything is restored, everything is sclerosed. You just have bone floating out of nowhere. You can see this. This is the pre and post Denosumab MRIs.
Yeah.
So one thing, Dr. Basu, is that one of the issues with Denosumab is long-standing. They can have what we call as fractures as we stop it. We've seen that in osteoporosis. If you look at it, they have what we call as the reverse fractures once you stop. So that's one thing you might have to
Yeah.
look for, correct? Because the quality of bone may be questionable as a long-term follow-up.
So I've had the chance to operate on a patient whom I had given Denosumab for 1 year, for actually 6 months before going into surgery. So this is a patient who came to us with initial myelopathy, and then after Denosumab it was shrunk, and then I operated on this patient. And the bone was extremely thick and extremely cortical.
Oh,
So
okay.
I have not found reverse fractures, but this bone was very, very cortical. In the long term, they might be brittle. Possibly 5 years down the line, they might become brittle because of excessive hardness, but I'm not sure.
Okay, wonderful. So we'll go on to the second session, the second part of the talk, I might say.
Okay, so this is a smaller part, which is the malignant spinal tumors. The classical example is the plasmacytoma as a multiple myeloma. They are, now, it is important to remember that plasmacytoma is basically a localized manifestation of a multiple myeloma. That's what all the hematologists or hemato-oncologists believe. But we as orthopedic surgeons, we do see plasmacytoma as a tumor, a primary malignant tumor arising from bone. But they all believe that today or tomorrow, this is going to spill out, and this is going to be a plasma cell neoplasm coming out of bone marrow. That's what their opinion is. And every effort should be made to rule out that it is not a multiple myeloma, and SPEPs and UPEPs and light chain assay, beta-2 microglobulin, they should all be checked up. In fact, some of the hematologists would suggest that before going in for any sort of treatment, you please do a PET CT scan to see whether there are other lesions or not. Of course, a bone marrow biopsy. So 5-year disease-free survival rate of plasmacytoma is 60%, whereas 1 and 4-year mortality rates of multiple myeloma are about 70%. The chances of fractures and progressive vertebral collapse in multiple myometers are there, and serum protein electrophoresis is used for diagnosis and response of multiple myeloma. So plasmacytoma is typically seen as a hypointense vertebral body on the T1. Radiotherapy is the treatment of choice for spinal lesions. Surgical intervention is done when there is either a neural compression or instability. And chemotherapy is to be started once systemic dissemination occurs. And in those group of hemato-oncologists who feel that a small spillage in the plasma cells of the bone marrow is actually on, they would suggest that you also give chemotherapy. I'll give you an example of a 54-year-old of a male patient. Now you can see this is a completely collapsed L1, and he's been bedridden since a month. And the moment he starts to get up, he gets tingling numbness, and he's about grade 4 with hyperreflexive jerks. It's just at the level of the corner, so he got his ankle jerks lost and knee jerks slightly brisk. With this, you can see that there's a typical cord edema, which translates into the lower part of the cord, and that's it. So in this patient, this is all soft tissue, and this will all come down with radiotherapy. So all I did was a percutaneous fixation, and by positioning itself, we could get back this vertebral height, leading to indirect decompression. I did not do anything else but a biopsy. Proved it to be a plasmacytoma, and this is 1-year follow-up, and this is 2-year follow-up. You can see that this becomes completely sclerosed. One of my fellows asked me, so I want to do an reconstruction because this is going to fail. And that's what I had predicted, that I don't think it will fail if it responds to therapy. If it does not respond to therapy, in any case, he's not going to make it, because then it will be a floated multiple myeloma, and today or tomorrow is going to die. All you need to do is to see to it that the spine is stable and not neurally compromised. So this is a 70-year-old female again. They're usually elderly, and you can see that also look beyond the spine. The skull X-ray shows the typical appearance, and the bone scan would show you these fractures. You know, these painful are part of multiple myeloma. We do not take up radioactive isotopes, and they're usually hypo on T1 as well as in T2, and the biopsy to confirm the diagnosis with a good outcome. Now, these are the myelomatous lesions. Now, let us talk about some related lesions. So, this is a 42-year-old male who presented with weakness of lower limbs, underwent a dorsal decompression biopsy elsewhere without improvement. That biopsy, unbelievably, was inconclusive. So, this was the X-ray. very early destruction, and this was the MRI. And I would always ask you to look for this engulfing lesions. Here, what you can see is that the CSF is blocked from above and below, and there is it's a blush of tissue all around the cord, and that is what is the engulfing tissue. And all we needed to do was to decompress. And this is the contrast film, as you can show. This is the cuff, as I say, the cuff of tissue all around the cord. This is the cuff, and all we needed to do was to decompress it. This does not require any reconstruction. As you can see, the bone has not collapsed, and so the diagnosis came out to be non-Hodgkin's lymphoma. This is the post MRIs, and as you can see, this is re-exploration was done, partial laminectomy of D7 and D10 was done, debulking was done, and histopathology turned out to be an NHL. So from a myelomatous condition, these engulfing tissues can be myelomatous, they can be lymphomatous in origin, and the immunohistochemistry will tell you the typical cell lineage of plasmacytoma as opposed to lymphoma. I do not have any personal experience of an osteosarcoma over all these years. I have not operated on a single case. They are usually, as you know, between 20 to 40 years of age, a little bit elderly as compared to those of the knee and the hip. And neoadjuvant therapy prolongs survival rate. This is absolutely proved. And this is one of the internet pictures. I do not have any personal experience. I do have a personal experience with a chondrosarcoma patient, and they typically occur in the 5th and 6th decades of life. With they might present as a palpable mass or with pain. Neurological involvement is common. Fortunately, these typical radiological features are easily picked up, and en-bloc resection with radiotherapy and chemotherapy is the treatment of choice. Survival rate depends on histological grading. For grade 1, it's more than 90%. It's about 65 to 80% for grade 2. Once it's grade 3 and anaplastic types, they are very poor prognosis. So this patient of mine, whom I have 6 years follow-up now, is a 71-year-old female. And as you can see, that there was a little bit of sclerosis at L1, and that is the lesion at L1, with a little bit of collapse and compression, but she was neurologically virtually intact. So we did a transcurricular biopsy of L1, and it came out to be chondro as grade 2. So surgery was done in stages because she had a significant amount of comorbidities at this age. She had a past history of ischemic heart disease with a angioplasty done in 2 vessels, and she had issues of diabetes and hyperlipidemia. So the first stage we did a D11 to L3 percutaneous fixing. We didn't want to open up the entire area, and with a micro open decompression at L1. We opened that much so that the entire posterior elements of L1 could be taken out, including the articular processes as well as the pedicles. And as you can see, after the first stage, you see this is the anterior part which is left, and everything is gone. Here is just a little bit blush of the part of the pedicle. Rest of this is all gone. And in the second stage, we did a thoracoabdominal approach and took out the entire body in a single piece. Typical en-bloc resection, and this is the X-ray and CT pictures of this specimen. As you can see, we've taken out entirely excepting the pedicles. Now, most of the pedicles was taken out from the posterior element, and this part of the pedicle was a small part, a wee bit of it was taken out from the anterior. So this is the second stage posterior second stage anterior surgery posterior pictures, and as you can see, this is percutaneous, and this is 1 year follow-up, and now she's 6 years down the line. She's maintained well, and she's still under follow-up. A very grateful lady who comes regularly on her first year for every year's follow-up. This is an example. I have one example of Ewing sarcoma, which is, as you know, presents in 2nd or 3rd decade of life. They are actually a variant of PNETs, which is the primitive neuroectodermal tumors. 60% might have neurological compromise and can present with pathological fractures. They have a permeative appearance in radiography with lytic lesions in CT scan. MRI is the investigation of choice. Neoadjuvant chemotherapy is useful nowadays, and some patients have some survival from a combination of CT and RT. And this patient was not so lucky because she had D6 spastic paraparesis, and the CT scan showed a complete osteolysis of that area. This was MRI, and she ultimately underwent a biopsy, which proved to be Ewing sarcoma. And it's actually not wise to go in and operate on this patient unless you have a very fastly progressive neurological deficit or a complete collapse, because these patients do respond initially very well so far as pain as well as shrinkage of the tumor is concerned. I have seen initial reversal of neurological deficits by aggressive chemotherapy. They should be best left to an oncosurgeon to decide. If the oncosurgeon decides that for the spinal stability purpose she requires surgery, absolutely well enough. But usually, considering the prognosis of these patients, an aggressive surgery is not on the cards. Chordoma is a typical spinal tumor, a vertebral tumor, which is a predilection to the ends of the spine, that is the C2 and the sacrum. More often seen in males, presents as pain and progressive neurological deficits. Imaging shows an expansile, invasive, and lytic lesion, with most of the lesions involving the sacrum, occasionally at the C2. Now, they are usually insensitive to radiotherapy and chemotherapy, and surgery is the only treatment of choice. It's important to understand that a wide excision, that means an excision to the margin of good soft tissue, is the treatment of choice. I would say this is the histopathological treatment of choice, because here you respect histopathology, but I do not think that in many of the situations by doing so you respect biology, because in many of these patients you lead up to a massive surgery and they are incontinent for life. Especially in males, this might be a major issue. This is a patient who had luckily his lesion was way below, and this was below S3, and once it is below S3, usually the bladder wall is not affected by resection, because if you can save one S2 S3 nerve and at least a part of, or rather if it is one S2 S3 and S2 on the other side, and resect the rest of S3 and S4 on both sides, you are going to do well so far as bladder is concerned. And this patient will be underwent an en bloc resection, and as you can see, this is the one end, and the other end is sort of incision, and this entire thing is coming out, and this is the specimen which had come out in one piece, and this is the postoperative CT scan. With this en bloc resection, neither become incontinent, but he had a good long-term follow. She is now 3 years down the line, but if it extends up to S2 and you have to take out the entire sacrum, that's a sacrectomy with a lumbar spine to pelvis construct and a very major surgery, which involves a bowel part as well as a posterior part, these surgeries are bound to make you incontinent throughout life. So a patient who is continent and has this surgery might have a lot of inhibitions. At least a couple of my patients have refused this surgery. And if it is not involving the bladder bowel, then it makes all the more difficult to make a consenting regarding the fact that you lose your bladder bowel permanently. A patient who has already had a bladder bowel disturbance or is incontinent might be a better candidate. Thanks for inviting me.
Thank you, Dr. Basu. Couple of questions. Wonderful, amazing work that you've shown us, but a couple of simple questions for our orthopedic colleagues. Do you send all your patients for a CT guided biopsy, or do you do your biopsies yourself? Hello?
Hi, Raghu, yes.
Yeah, so can you hear me? Did you hear the question? Or
Yeah.
Yeah. Okay. Hello?
Yeah, I can hear you, Raghu.
Yeah, so the question was, do you do as a concept in your practice to send these for a CT guided biopsies, or you do your biopsies yourself? What's your practice? I mean,
as I showed you in the first presentation of a chondroma, which is actually spilled over from the bony margins out into the exterior. In these patients, a CT guided FLSE is good enough because the margin of the lesion is way beyond the margins of the bone, because it's an expansion lesion, partly soft tissue, partly bone. So it's a very high chance to get a CT guided wide bone liquid biopsy. But if it is an intra-bony lesion, for example, if it is an intra-bony osteoblastoma, or anything which is completely surrounded by bone, I would be very loath to do anything but a transpericular biopsy.
Dr. Dhar, you want to ask a question?
Yeah. Thank you, Dr. Basu. Again, amazing X-rays. Thank you very much. I want to talk about myelomas. Like, do you treat them as metastatic disease, or like you use the same SIN score or use norm framework, or you would rather go ahead with this radiotherapy and then think of a surgery in case there is a residual neurodeficit or there's a mechanical instability? Do you treat it as differently as a metastatic disease?
I intentionally did not want to come out with these tokuhashi, SINs, and all these scores, because understanding that I'm speaking to a host of orthopedic surgeons, this would be too mechanical stuff for them. But as you correctly pointed out, these tumors should be considered in terms of the SIN score, as well as in terms of their of an understanding whether this is a metastatic disease or a localized disease. To my understanding, 50% of plasmacytomas are localized disease and 50% are metastatic. This is not evidence-based. I cannot go to a literature on this, but as a sort of a hunch, as a sort of a generalized clinical feeling, I would tend to believe that if I see a patient of a plasma, if I see a patient of a multiple skip lesion, that's a different ballgame. I see a patient with features of a solitary involvement, which on CT guided or on transpericular biopsies come out to be a plasmacytoma. I would suggest to myself that there's a 50% chance that it is actually a multiple myeloma. For that, I would definitely involve a hematologist or a hemato-oncologist into it, so that he does an array of investigations, including radiological as well as histopathological, bone marrow, and all those tests. If he is also convinced that at this point in time, Dr. Basu, I cannot tell you it's metastatic disease, then only I will treat it. I will consider it to be a locally aggressive lesion. Now, having considered it as a locally aggressive lesion, I would look at it in the form whether he has an instability with significant pain and a potential neurological deficit come up, or which has already come up. In those instances only, I would do a surgery, and I would definitely not aim at a radical resection, en bloc, and all that. I will aim at stabilizing and decompressing with the minimal amount of effort and leave the rest to my hematologist colleague.
Have you had, Dr. Basu, in the last so many years of your experience, any patient that you actually planned to intervene surgically and had to not do it because of medical fitness and then had to look for a backup plan? Most times, sometimes.
Raghu, I missed you. Come again.
Yeah. So have you had a scenario where you kind of planned the entire surgical intervention for a patient who's been diagnosed with a biopsy before, but had to not do it because of medically not being fit? I mean, scenarios where they're not fit enough for surgery. And what was your backup plan then? I mean, have there been scenarios in your practice where they have not been medically fit?
So I would look at it in two sets of real life scenario. One is a patient, say a patient of a chordoma, whose treatment is wide surgical resection, nothing else, nothing more, nothing else and nothing less. So in the discussion with the patient party and the patient himself, if I feel that he is not fit to undergo a massive surgery, I would always say to him that backup plan is to do a debulking, let it recur, and do a gainer debulking, and let it recur, and again do a debulking. I have one patient whom I have done 4 surgeries on a chordoma patient, and he is still reasonably continent, and I have followed up. I mean, this is the 6th year of her life. She's going to die now. She is in a sort of an inoperable recurrence, which I cannot operate anymore. She's going to die within a few months, I'm sure. But I have pulled her along for 5.5 years. Yeah. And all these 5.5 years, she never had to use a catheter. Yeah. So I would say that, other than during the perioperative periods. So I have won the game. But if I actually would have lost the patient trying to do a massive radical surgery, then I would have lost it on day 1. So that is one scenario. The other scenario is a patient whom you know that the pathology is such that it's not curative. For example, if you're bound to go in to a patient for a Ewing sarcoma or a metastatic disease of the spine, in which the life expectancy is 1 year, I would never try to be aggressive. I'd just do something which is minimal.
Dr. Basu, even in chondrosarcomas, how you would suppose you feel that it is an arm block resection is possible. I have my own experience with chondrosarcomas. They actually do well even with sort of debulking and getting a good sort of separation surgery and then treating them, and they do well. How means I'm just wondering, because I have not done a arm block resection. So means what would you weigh? Means you would still go for an arm block resection knowing that they might do still well with because in areas where you may not be able to do a good arm block resection.
So it depends, Sanjay, on the histopathology. If it is a grade 3, if you're not doing en bloc, you are definitely not doing the correct job. You might not be, you might be pushed for situation facility-wise or the patient's comorbidity-wise. You are not able to do the en bloc. That's a different ball game. But the aim for a grade 3 chondrosarcoma is to do a complete resection, because we know that radiotherapy and chemotherapy does not do well in these tumors. But if it is a grade 1 or a grade 2 chondrosarcoma, even if you do a piecemeal job, even if you do an incorrect job, the rest would be taken care of by chemo and radio. You might have a good chance to do a fair job.
On your grading.
Yes, it's a histopathological ballgame. It's not a surgical ballgame.
Agni, you want to ask any questions?
No, sir. I think
Agni is all fired, yeah.
Agni is traveling. Yeah, he's there, back, traveling.
So I'm parked on the rooftop parking. So I'm listening to the lecture. It was very extensive, very nice. One question which comes to my mind as a clinical scenario, which I want to ask, sir, is that you get a patient who has got back pain and a neurodeficit. It's not sort of paraplegic, but it's say grade 3 or grade 2 power. And you do a MRI and you suspect that it's a metastatic lesion or a malignant lesion. So how do you approach this patient? Like, do you take him up for surgery immediately, or you sort of work him up, wait for a day, or try? How should we approach this patient? Because we should not land up in a situation where we get into the surgery and then we are in a bigger sort of trouble than we originally were. Sorry, in the bigger trouble than we originally were, and we cannot delay the patient also so that he rapidly deteriorates. So in these scenarios, which we face more often, how should we proceed?
So it's an age-old discussion, Agnivesh, of biopsy first or surgery first, and the surgeon tends to differ. So he is deteriorating fastly. How can you avoid a surgery? And the patient party and the oncologist telling you, yeah, he's going to die within 3 months. So what the hell are you doing for surgery? Biopsy karo, get a radiotherapy and chemotherapy and pack him off. Palliative care karo. So it's an age-old discussion. I mean, what tilts the decision in favor of surgery is a patient who has a very fastly progressive neurological deficit, not a soft but a dense neurological deficit, which is progressed in a few days. A few days back, he was walking, and suddenly he's become paraplegic, or he's becoming fastly paraplegic, still spastic possibly. So that is a patient who have no option of waiting for a biopsy. At the most, you can do a frozen section. That's it. You have to go for surgery, and the surgery should be as rapid as possible, going out with decompression and fixation, with a caveat that if it is a pathology which ultimately surgery is the cure, for example, a cordomal, you might have to come back and do the full job after the biopsy is available. But for the first time, you just do decompression, fixation, and that's it. And if it is a patient who does not have a deficit or just a little bit of flying jerks, and that too is quite a sometimes he's still walking. He says that I feel a little bit of numbness while walking after 2 minutes. I have to sit and all that. Examination is grade 4 power, at least with flying jerks. In this patient, I would not jump into surgery. I would definitely do a biopsy and wait and watch and see what the result is.
And maybe start some steroids if it's cord or something. Sir.
Maybe I can give some steroids. But remember that if it is a lymphoma, steroids will rapidly sort of destroy the histopathology.
Yes, that is true, sir. All right. Raghu sir, any more questions or that?
Oh, you are the master of ceremony, so you go ahead.
Okay. So thank you very much, Basu sir. It was really amazing. It's always been a pleasure to listen to you and to your teachings and talks since the last 1 decade, which I have been associated with you. And every time I learn, every time I hear your lecture, it's something new and it's something which I really enjoy listening to you. And it was very informative. And we really, on behalf of NMOA, I really thank you for joining in and enlightening us with this topic. So if there are no more questions, Raghu sir and Dhar sir, with your permission, can I call off the meeting?
Thank you. Thank you very much,
Thank
Dr.
you.
Basu. Thank you, Dada.
Thanks Raghu,
Take
Sanjay, and Tiku, and Niraj.
And stay
Thanks.
safe.
Take care. Bye.
Yeah.
Thanks.
Thank you, Dr. Neeraj. Thank you.